Assalamu alaikum. The short clinical station day. First scenario, John Smith, 32 years old man, present with progressive weakness and fatigue in his lower limb. Proceed, examine his legs. You can start now. Here you go.
Okay, so I would sanitize my hand and go inside, read my command, and greet my examiners. Then I will take a few steps back to inspect the patient from far and the surrounding. Okay. Is there anything in the surrounding? Wheelchair, crutches, stick, or
Yes, there's a
floating?
wheelchair.
There
There's
is
a
a.
wheelchair. There's a wheelchair. Yes.
Okay, and then I will look at even if there is anything else. If nothing, I will come near to the patient. Since my command is examine the lower limb, I will take a look, inspect the lower limb for any fasciculation. I will trigger the fasciculation if there is no. Look for scars in the popliteal fossa around the knee, around the ankle. Look for any deformity, any abnormal postures, any, as we said, wasting, also discrepancy in the muscle bulk or disuse atrophy. So if there is nothing, even there is no signs of peripheral vascular disease like a scanty hair, shiny skin, or any.
I've sent the images.
Yes,
There's
in the chat box, you
yeah,
can
there's waste.
see the.
Yeah,
Yes.
there's
Okay.
wasting of the left,
Oh,
of the right, the right side.
okay, right. Yes, I can
Mm.
see that there is the right leg, and also it
Mm.
seems that he has hammer toes.
Yes, on the left, on the right, there's a past cables. Yeah, on the right,
Only on the right, because the
only
right
on the right. Yeah.
feet is not visible. Okay, then
Mm.
the right has pes cavus plus wasting. Okay,
Mm.
while the left is normal.
Yeah.
Okay, unilateral. Then I would like now to, after inspection, I would like to start with the tone. I will do the rolling maneuver, and I will also check the tone around every joint, especially the knee and ankle. How is the tone,
Okay.
especially in the right side?
Yeah, the tone is reduced in the right side.
Reduced, while normal in the,
Yes,
or also
while
affected?
normal, while
No.
normal in the left. Mm.
Okay, then I would like to go for the power. Okay, I will ask him
Okay.
first to elevate both legs with no interference in the air. So is he able to do that?
Yes, you can do that in the left, but in the right, the power is reduced. Power is 2 to 3, yeah, 2 plus.
So he can move it
Mm.
side by side only, along
Yeah,
the
only side
plane
by
of
side. Yeah,
gravity, but
yes,
not
yes.
against. Okay.
Not against.
What?
Yeah,
And so it is 2/5. I agree with you. While the other leg he can elevate. Okay, then I
yes.
will now examine each muscle group against resistance. So first I will start with the hip flexors, extensors, abductors, and adductors around the hip. So how is the power proximally?
Proximal is reduced. It's the same power, 2 reduced.
Okay,
Proximal
two
on
over
this side.
five and
Yeah,
in the right side and 5/5 on the left side. What about the
yes.
power in the knee flexion and knee extension
Same, 2. With same reduced also,
and plantar
2/5.
flexion and plantar dorsiflexion, plantar flexion
Reduced also.
and big toe big toe extension
Yeah, be reduced in the right
in the
and
right
normal in the
side?
left. Yes.
Okay, then I would like now to move from the power to reflexes. I will ask him to keep his legs floppy as much as possible, bring the hammer, feel the tendon, and then hit him after taking his permission. How is the reflexes?
The reflexes are reduced in the left.
And
In the right, sorry.
even with
They are normal
gynectic,
in the left.
I
Reduced
know,
in the right. Yeah.
even with reinforcement or gynectic maneuvers?
Yes, still reduced.
Okay, so knee and ankle, both of them reduced in the right side.
Yes.
Okay, then I will now go from to the clonus. Is there any clonus?
No. Clonus absent.
Okay, then I will go to the plantar reflex. Is the
Is down going.
down going both sides,
Yes.
right?
Both sides. Yeah. Mm.
Okay. Then I would like now to go to the sensation after reflexes. So I will start with a cotton wool and pen prick. Do the examination on the sternum, and then ask the patient if he can compare equal to the sternum or less or absent. and if there is any difference between both limbs. First, I will go dermatomal, then I will go in peripheral neuropathy distribution. So is there any patchy loss or
No,
peripheral
no. It's
neuropathy?
sensation intact.
Intact. And the
Yes,
deep sensation, the proprioception and vibration?
normal.
Normal. Okay. And then I would like to go from sensation to coordination. Can you please do the heel chin test, and I will teach him to slide from knee to the ankle, then elevate, then again from knee to ankle.
1
It
minute
can do
left.
it can do in the left side, but in the right side there's difficulty to raise the legs up that high enough. So it's not coordinated in the left side. Is difficult because you cannot raise the leg up.
Okay, but in the right side it was normal.
It's normal, yeah. But the left side is it's difficult for him to raise the leg up to do the knee to chin.
Okay, no problem.
Mm.
So I would, while I'm examining him, I would observe myself for his speech and nystagmus to guide me at least. Okay,
Yeah,
I think
speech is normal. No
speech
nystagmus.
normal and no
Yeah.
obvious nystagmus.
Mm.
Okay. Now I would like to go to 1 minute remaining gait. Can he take a few steps, or he's on the wheelchair? He cannot ride.
Yeah. I mean, he can try, but he's having what they call the hand to new gait.
I didn't get you. What?
He's having what they call quadricep gait, hand to new gait. When he walks, he puts his hand. Let me show you what he did. I would send the picture to you just now.
So you mean he support his proximity?
Yeah, as he walks, he supports his hands to his knee to walk. I'll send the picture now, if you don't mind.
He's using the hand to walk.
Yeah, to walk, to support his knee. I'm sending, Dr. Baza, I've sent you the picture, if you don't mind.
Okay. Send it to me.
Mm.
So you mean the picture when he stand up, there is a
Yeah,
Yeah.
but
myopathy?
yeah,
He need
he
to support
supports his, yeah,
himself.
yeah,
Okay, and what
yeah,
He's
about
using
what
he's
about
using the hand to support his walk. Okay, this
is
is the
what, yeah.
photo. It's more clear here. You can see Dr. Hint.
But in the reverse leg, I sent the other leg, right? So just know it's not the same picture, but it's like,
It's spot
yeah.
diagnosis. Okay,
Mm.
after this photo, we'll start the examiner question, Dr. Hind, because time is
okay,
up. Okay, you can see
okay.
the photo
And
clearly.
okay, this is the last step, the gate, agree. So I would like to offer, until I see the picture, offer upper limb examination, cranial nerve examination, inspection of the scalp, neck, and back. And yes, this is the main thing I would
Okay,
like.
the photo in the chat box if you want to confirm.
So this is
Yes, clear. I hope.
okay.
Yes, Dr. Hina, you can start the questions.
Can you present the positive findings of your patient?
Okay, the positive signs on this patient, I could notice that there is a wheelchair, okay, a wheelchair in the surrounding, on general inspection with wasting and pes cavus on the left side, okay. On local examination, the patient have signs of lower motor neuron lesion affecting again the right side, even the wasting and pes cavus on the right side, and signs of lower motor neuron lesion in the form of hypotonia, hyporeflexia, even with reinforcement, and also power. It was around 2/5, and reflexes and sensation were intact. Coordination was difficult to perform because of weakness. There was an obvious proximal myopathy when standing, and he has a waddling gait, I suppose, from the screenshot. Okay.
Okay. What are the likely likely differential diagnosis in this patient?
Okay, I would like to pick for this patient, since he has unilateral with signs of chronicity, unilateral lower motor neuron with signs of chronicity. I would pick something like how old is he? Young? Like this guy is young. So I mean, when I look at him, so if he is a young patient, I will think of poliomyelitis, multifocal motor neuropathy. Also, I would think of motor neuron disease, and because it's asymmetrical and there is no sensation, so this is my differential.
I will investigate this patient.
Maybe I can add CIDP, the variant which has no sensation or minimal sensory symptom, because CIDP can predominantly motor and can come with signs of chronicity.
How will you manage this patient?
Management is mainly supportive in these cases. First, I will make sure of the history, how long he had this, and mainly it will be a multidisciplinary team, including supportive groups, PT, OT, social workers, podiatrists to help him in orthotics and walking aids, and neurologists to follow up him. Also, we need to any lifestyle changes like needed to be taken. Driving has to be addressed. What else we need for this patient? It's mainly symptomatic treatment, and if it has any, like, I mean, weakness elsewhere, it has to be addressed.
Okay. All right. Can I comment? Or you still have time for examiner's
Still 1
question?
minute. You finished the
Okay.
management plan, the
Okay.
investigation, the differential.
Yeah, investigation. She didn't mention investigation. I asked.
Yes.
Investigation.
I would like to investigate this patient by routine investigation as usual, and I will add extensive electrolyte profile. I will add also inflammatory markers, CBC, LFT, and RFT as usual. And I would like to do nerve conduction study, okay, and EMG for as a prognostic modality. And I would like also to look for if there is any if we are thinking about multifocal motor neuropathy, we might do some markers like autoantibodies. And that's the investigation, mainly clinical, the diagnosis, supported by the investigation I have mentioned.
Okay.
Okay.
All right. Thank you very
Yes.
much. You did well. You did well. You know, if with the permission of Dr. Bazim, can I score with the looking at you did very well for your examination, your your type A skills, which was okay. It was perfect. I'll give you satisfactory in that regard. For the physical science, you were able to pick some science. You pick but you didn't mention when you are giving when you are talking about, you didn't mention the pes cavus that the patient had. Did you mention it?
I
You
mentioned
mentioned
wasting
okay.
and pescatus on the right side. Yes,
Lovely. Did you mention the limb length discrepancy?
Yes, I said wasting and pescavus on the right side. So
No.
this
Did you mention limb length discrepancy?
okay. No, because I
Okay,
cannot see
lovely.
the end of the right, but maybe yes, it makes sense.
Okay, lovely. Okay, but it's still okay. I'll still give you for the. Did you ask of if I have pain?
Pain? No, I didn't ask. Maybe
Because
we
this
can
patient,
start
this patient has.
consultation.
Okay, so you didn't ask if I have pain. Good. Also because it's also key in this patient for your welfare. That we lose mark. The
Yes, I
welfare
get
in
you. It has to
you
be
get.
checked
Yeah,
in the beginning of
and
the visit.
yes. Did you introduce yourself very well? Did you ask for the patient's name? Because I noticed that you didn't know the patient's age, and it was given to you in the scenario. Two, it was given to you in the scenario. The patient's age and name was given to you, but you
32.
you keep
Yeah.
you keep on asking of the age during the course of as it's like you forgot the age when you
Yes.
are examining this patient. So also patient welfare, I'll give you unsatisfactory with patient welfare because of
Okay.
you didn't ask for pain, you forgot the age of the patient, you
And
didn't
I
know.
ask
So
about the
for the welfare it was unsatisfactory. But for the physical sign, satisfactory, the clinical judgment in this case, your clinical judgment, because of patient has what they call post-polio syndrome because of the pain he has, but he didn't ask for the pain. You also have some pain along that region. There's polio. So because of that, I'll just give you, and the differential diagnosis, well, polio is okay. Because of that, he didn't really complete it, kind of, not just polio. The patient came in, this 32 years old, you don't expect a fresh polio to affect a 32 years old coming, presenting with this regard, with weakness and
I
fatigue.
should say, rather than poliomyelitis, I should say post-polio syndrome because of his
Yes,
age. Okay.
because of the history of that was given to you. Maybe Dr. Basim might have some words to add there, but that is what I think. So basically, it is more like post-polio syndrome because of the presentation, progressive weakness, and fatigue. It's coming out a new. It's not because you don't expect polio to affect at this age group. Usually seen
No,
probably in young.
I get you to use the correct term based on his age.
Yes,
It's
yes,
making more sense to
yes.
use
So
post-polio syndrome. And you are
yes, so
totally
okay. So for the clinical judgment, I'll give you borderline in that case. So
okay.
I don't know. So I've in my own scale, I think that is my own correction here in terms of outside that you did very well. You did very well. You for the also you for the you're able to ask to investigate where you mentioned EMG, but however in the exam I would have loved you to say what you see on EMG. You see chronic denervation and reinnervation. Basically, that is in keeping.
We
So that
see,
is what you see.
wait a minute. We see what on the EMG? Can you repeat?
Chronic denervation and reinnervation on
Chronic
EMG and
denervation, chronic denervation and re-innervation. Okay.
yes. So these are the things you want to see in this patient, basically. And also you also don't mention routine what you just said in the exam, that outside routine investigation. Say those things in the exam.
Okay.
Just that because of that thing you said to your mark to be reduced in the what do you call it again?
Judgment. Because usually
Judgment.
investigation
Yeah.
are under judgment.
Yes. Yeah. So the judgment. So these are the things. I don't know. These are my correction. Outside this, I think you did well. Did well. Thank you very much.
Thank you, dear. Thank you for the comment.
Yeah, thank you, Dr. Henry.
Mm.
I agree. I will add only to the comment and to finding physical examination the short limb. Suppose
The
this patient will have
discrepancy,
short.
she told me there is a discrepancy.
And then the gate, the gate
Yeah, limbing.
the gate was not correct. The gate you mentioned was not correct. You
Okay.
It's not
mentioned
short limb. It's
Ataji gate.
limbing. Yeah.
Yes, the gate you mentioned, you gave a wrong gate. So because of that, you added sign that was not there. They'll just write
Okay.
it in your
I
comment.
thought I thought it was like a waddling gate because you told
No,
me he
it was not
was
waddling gate.
standing. So
It
I
was
get you, but really
uh,
he's raising his right leg, so this means that
yeah,
it's
yeah,
not touching the floor equally to the left
yes. Mm,
leg. Okay.
thank you.
Yeah. So the gate will be limbing, right,
Yeah,
Dr. Henry?
limping gate, yes,
Limbing
or
gate.
probably you can call it the hand to knee gate, or also known as the quadricep gate. It has so
Okay.
many names. Yeah, so that
Yeah.
called quadricep gate. There are many gates that you can see in polio. We have Chendenberg gate, or in which that's not what he has anyway. Polio can also have what they call the hand to knee gate, which or the
Please,
quadricep gate.
write the names of the gates in the WhatsApp because it's
Oh,
really
okay,
new for me. If it's okay
okay.
with you.
I'll do that for you. I'll do that for you if
Thank
you
you
don't mind.
so much.
Yeah.
Yes. Plus the short and short limb compared
And
to the other limb. Supposed to be also atrophied, some muscle atrophy,
mhm.
and foot drop. This I think spot diagnosis, Dr. Hindi, you will never miss the case if you see the
ما بعرف
patient
أنا ليش
in
مبين
real.
معي الرايت فوت طايرة.
Supposed to be the opposite. Yes, he's limping on the left, but
Yes, it's supposed
Dr.
to be the
Henry,
opposite. Sorry, I made a
the
mistake. It's supposed
opposite
to be the opposite
exactly.
leg. Yeah,
Yeah,
sorry.
No بس حتى الرايت فوت مو مبينة معي بالصورة. يعني هو مبين معي الهيل بس.
yeah. Maybe it's shorter, maybe,
Mm,
but
بس
I
yeah,
this is
think also it's the opposite of the gate. Suppose he will
yeah, it's
okay.
use.
opposite of the gate. Yes,
بس
I made a
already I
mistake here.
agree إنه عن جد I should correlate إنه
Mm,
he has a chronicity unilateral وأنا حطيت بوليو فأكيد limping gait rather than muddling gait.
mm,
Okay.
Yes, exactly. Okay. I think you cover all the investigation well. The management plan, you mentioned the orthostosist to help the patient to
Okay.
cope with that, yeah, with the walking. Wheelchair, occupational therapist also can be added. It's very nice case and easy case if you see the patient from the first look. You can diagnose the patient. Post polio, it's common case you can see, but it's not in the developed countries. It's in the developing countries. Anyway, Melody, they are bringing such cases in cases. Okay.
Okay.
Anything else, Dr. Hina, you want to add? For the
I think
differential,
basically,
yeah.
yeah,
Can you
for it,
repeat the differential?
for in this case, that for the differentials, like typically the differentials, you have to rule out other things. like anything I'm mentioning, for instance, is polio will give you typical, like if it's like in my own case, my patient was similar to this, but it can be congenital, but in this case, it is unlikely to reach. My own patient that have similar case like this was a 35 years old female who have similar case like this, but they said it was more of a congenital, left right hemimelia. So, but that is, it can be a congenital case basically. In this case, we have similar, there will be what do you call the weakness will be normal. Sorry, there will there'll be no atrophy of the limb, but there'll be typical. It might have some, pes cavus in that case, and also it may still be other differential diagnoses that they may not have pes cavus but have similar pattern. May also be lumbar spondylosis. They may because of the pain that he has, but he didn't get the pain since he didn't pick the pain. In this case, lumbar spondylosis, we have pain. We also have a degree of weakness also in that particular limb, and also some radiculopathy, like I mentioned, could have similar pattern too. Also, in
Only
keeping
I
typical,
didn't pick radiculopathy because no sensation, no
no sense.
dermatome.
Yes, that is what the drawback. That is however, there will be sensation in radiculopathy. You are right, and also too for that weakness for the weakness that is it could be also be sciatic nerve injury, and also in that case too, you may tend to see some sensory affectation in the regions of the sciatica. But basically it is the main diagnosis is polio, because there's no other thing that we tend to have similar pattern with polio.
Yeah, but there is
However,
what's called Post-Polio Syndrome and poliomyelitis, right?
polymyelitis, yes, yes, and also you can see mention what do you call it? This what do you call it? Mononeuritis,
Mononeuritis
multiplex.
multiplex, yeah,
Yes, you can
peroneal
mention that
nerve.
one too. Yes,
Even
basically.
mononeuritis multiplex, do you agree with me or not that it need to be sensory and motor?
Yes, it may be
Yes,
sensory
yes,
investigation too. Yes,
yes.
basically. That is just that. I think,
And it will be
It will
food
be
drop.
unilateral. It will be unilateral and no
Exactly.
chronicity
yes,
sign. No
yes.
chronicity sign because
No
it's usually
chronicity.
acute and resolving. So I would put it if there is sensory and no chronicity, it work
Yeah.
mononeuritis multiplex. I agree.
And there is also food drop in the peroneal
Yes.
nerve
Mm.
pulse. Okay, thank you, Dr. Neri. Good case, and maybe a first time to do it here, or maybe we did it before. Anyway, it's helpful to have this case as a review, and also if you have in the exam, it's a good case. Really, you can know the diagnosis from the first look. Okay, Dr. Hindi, you can post your scenario for Dr. Henry. We can start the second scenario.
طيب اوكي بس اذا ما عندكم مشكله انه نكتبه سوا لك انا فيني اكتبه لاني انا فاتحه الشات بوكس على الجوال. 48 year old woman came with itchiness. Please examine ما نعرف نكتب examine the abdomen. اوكي وخلاص that's it. Okay, this is the case.
So we'll start straight away, Dr. Henry.
Okay.
Abdominal examination. You can start now. Here you go.
Hello, I'm Dr. Henry, one of the doctors here. I confirm you are Mrs. AY, a 48 years old. Okay, I've come to examine you. Do you mind if I examine your tummy? I'll be very gentle. If I eventually feel any pain, please do it to let me know. Can I please go ahead? It's
Yes,
okay.
you can, please. And I have no pain now.
Okay. I suppose the woman then go to the foot of the bed and check, do general inspection, look at and see. Then can I see your hands, please? Look at the hands and then check for the finger, any finger clubbing, check for deep contraction, check for any palmar erythema. Then look at the nails and everything, check for flapping tremor, check for any flapping tremor. Then look at the hand.
There is no flapping tremor, but you what?
No flapping tremor. Okay. Any tremor?
There is no tremor. No tremor and no flapping tremor.
Okay. Then look at the hand, check for any fistula in the hands. Any fistula.
There is no fistula.
Okay, then look at check the eyes. Go to the eyes, check for any pallor, any jaundice.
There is pallor and there is tinge of icterus.
It's okay. Then look at the mouth, check for anything in the mouth, any gingival hyperplasia, any sore in the mouth, anything. Look at the roof of the tongue, check for dehydration, and then look for cyanosis. Check for the lymph nodes, cervical lymph nodes, axillary lymph nodes, anything there at the back.
See, the cervical lymph nodes are negative.
Okay. Then go to the check look at the axilla, check the breast, examine the breast, tell the patient to raise his hand, then examine the breast, the two breasts, any gynecomastia, any spider nevi.
There is, when you look at the patient, no chronic liver disease stigmata.
Oh, okay. Okay, lovely. Then look at check for the tummy. Do you have any pain in your tummy? Then go to the 9 quadrant, check in the 9 quadrant of the tummy and see. Check 9 quadrant, anything, any pain.
In what
Before any scar, before checking any scar, look at this. Look up any scar in the tummy, any scratch mark. Since it's itching, check for any scratch mark.
Agree with you about the scratch mark. You could notice in multiple area of the body there is a scratch mark. Don't forget, I'm sending my picture in the group because it's easier for me. I send you 2 pictures, one in the hand and now I'm sending you the abdomen. What you could notice on inspection. بس ما بعرف شو بالنت عندي. يلا, it's just like seconds. It is there now.
Okay, let me check in the group. I'm sorry. Okay.
Okay, I will share them right now in our the chat box. Okay, you can see them. Dr. Henry, both photos are shared here.
Is that it? Is that the tummy?
The
okay,
hands,
there's a scar.
the hands and
the
the abdomen. Yes, you can see both in the chat box.
Okay, I can see them now. So I've looked at the hands. Okay, lovely. Is there any thickening of the skin?
Thickening? No thickening of the skin. Rather, there is thinning of the skin.
There's thinning of the skin. Okay.
Yes.
Then look at there's a scar in the tummy.
Yes.
Is that 2 scars? I'm seeing one at the
you have to use the correct term when you present describing the scar. But okay, good. There is one scar, as you said.
Okay, no, I'm seeing 2 scars. I'm seeing 2 scars there, if you don't mind. Except maybe I'm not seeing very well. I'm seeing 2 scars in the tummy.
One above the umbilicus and one in the right costal margin. Agree with you.
Yes. Okay. Then I because any pain, any tenderness, any organomegaly.
There is very mild tenderness when you press in the superficial palpation.
Okay. What of deep? Where is the tenderness? Which part is the tenderness?
In the right upper quadrant with no organomegaly.
Oh, okay. Okay. Then I go deep. Then anything in deep.
In the deep palpation, you could induce more pain. So the examiner told you, please don't do it. And you couldn't feel any masses.
Okay, no masses. Okay, lovely. Then ballot the kidneys, check for ascites, anything?
Perfect. There is no kidney ballotment negative and no tenderness in the loins.
Okay, no tenderness in the loins. Okay, then ask then after when I'm done, and now I have to auscultate, listen at the check for the bowel sound, check for the renal brew, and then ask him to cough and check for any annual orifice.
Okay, bowel sounds are positive. Renal puree is negative. When the patient coughs, there is no signs of herniation.
Okay. So, looking at is okay. All right. Lovely. All right. Thank you very much.
Do you want to offer anything?
Yes, I want to offer digital examination and then urinalysis. Yes,
you want to offer, what did you say before urine analysis?
Digital examination.
Yes, you are right. And it would be wise also to finish with the bibasal crackles and sacral edema from the back.
From the back, okay.
Yes, and you would have a chance to see if there's any spider nevi because sometimes they are in the back, not in the front. And also don't forget to check the axilla. And do you want to do anything in the lower limb, dear?
Yes, I want to, in the lower limb, I want to look at the check for pedioedema in the lower limb.
Agree.
Pedioedema in the lower limb. Yes, and then
Okay.
check for any tendons and xanthelasmas.
In the Achilles tendon, if there is anything
Yes.
to guide you for the indication of the transplant. Agree. Okay, so I think we are done. Can you present your finding?
Okay. I've examined this gentlewoman who on examination, general inspection, there's
She's a
obvious
woman.
case.
Woman,
Yes, this
yes.
woman. Yes, that's gentlewoman. Yes.
I will cut you in the welfare.
No. I said gentlewoman. This gentleman who on general examination, I noticed there's a scar with a umbilical above the umbilical scar, and then there's a scar on the right appendicular region. And also noticed she's pale with and tinge of jaundice tinge of jaundice. I have no signs of chronic liver disease, and looking at with no organomegaly and with no organomegaly and no lymphadenopathy. Also, looking at my examination, I'm attending that my patient has had most likely has a surgery, a liver transplant, a surgery likely maybe due to liver surgery. Most likely had a surgery, chronic a surgery from likely due to could be autoimmune hepatitis, could be cholecystitis, could be primary cirrhosis, primary biliary cirrhosis, and could also be due to primary sclerosing cholangitis, basically. I think
Okay, agree. So you don't know exactly what is the etiology because there was no. It is better when you present to tell that it is liver transplantation for and the etiology for differential diagnosis, but I couldn't appreciate any signs indicating the etiology in my examination. Other than being a young woman, it could put her at risk of autoimmune, like autoimmune hepatitis, primary biliary cholangitis. Agree with you because those are the only indication. You couldn't see xanthelasma, you couldn't see, for example, tattoo, you couldn't see anything could guide you toward the etiology, hyperpigmentation, hemochroma, nothing. Only women, young age, put her at risk of autoimmune. But you should be honest that there was no signs for indicating the etiology. So the etiology for differential diagnosis, taking in account taking in account her age and gender, I would give autoimmune top differential.
And
طيب
finger brick marks.
yes, she forget. Now I will go through what she forget. The finger prick marks are indicative of what, dear?
Yeah, I think the fingerprint marks may be indicative of the diabetes.
And also
Maybe
you could pick up something else, the thin skin, right?
yeah, the
Since
thin skin. Yeah, maybe
so
we
what you
use
should
those.
present in your presentation in view of the prick marks and the thin skin,
In view of
is there
most likely
are signs of side effect from what?
from steroid.
Yes, or from immunosuppressive, most likely
Immunosuppressive.
steroid. Always
Yeah.
use probabilities because you don't know what the patient is on. You are expecting that in view of this prick marks in the tips of the finger and the thin skin. And I would love if during your examination it was perfect you check tremor, but you forget to check alopecia. You forget to check gum hypertrophy.
Mm,
You
mm,
didn't tell me in the neck. I would like to see if there is any melanomas, squamous cell
mm,
carcinomas, skin
mm,
cancers.
mm,
Okay. You didn't
mm,
tell me. I would like to check the interscapular fat pad,
mm,
supraclavicular fat pad, those stuff which indicate to the to the examiner, like for example, is the face is round, plethoric. So it would give me like, do you know, a clue that you are looking for all the side effects of immunosuppressant. Okay?
mm. Yeah,
So
yeah,
even in the mouth, please, please, in the abdomen, wallahi, I made it a habit, and really it
yeah.
gave me a credit in my exam to check the gum in the abdominal station.
Mm,
Guys, we open the mouth, we put the torch, but we don't flip the upper lip and the lower lip. And most of our differential in the abdominal station are lymphoproliferative and myeloproliferative, where gum hypertrophy is very important. Plus, if there is a transplant. So keeping this step in our abdominal examination, it's really gonna show the examiner that your differential is based on, or you are basing the steps, and you are taking steps, extra steps, because you will put something extra in the differential. So let's go now through the presentation, through the steps of examination. I would love if from the start in the abdomen, you took a few steps in the back and you tell
Dr.
me, I
Hind,
would like to
you can
inspect.
still ask him about the investigation
Yes
management.
yes صح, the investigation. بس يا الله لا بنسى أنا نساي
Okay.
الأشياء
All right.
Okay,
Okay.
tell me how you will investigate.
Okay. Investigation will involve. I'll start by doing liver function tests, complete blood counts and differentials. I want to do abdominal ultrasound scan. Also check for the abdominal ultrasound scan. I also want to check for the since they had the surgery, to check if there any the level of the examine the liver and then see the other organs that are involved. And also part of investigation to this, I want to do alpha fetoprotein to see if there's any malignant transformation, alpha fetoprotein, and then want to do other imaging, other what do you call it, other tests such as other markers like inflammatory markers like PIFCA, vitamin, other markers of. Although in this case is on. At least these are the investigation I want to do: blood, liver function tests, full blood counts, alpha fetoprotein, then abdominal ultrasound scan, basically, and then monitor the level of the if it's on tacrolimus, which is not. Want to monitor the TAC level, and then
All drug
basically
levels, stay
drug
open,
level,
all drug levels, because
all
he
drug
might be on
levels.
cyclosporin, tacrolimus, mycophenolate
Yes.
mofetil. So I would like to do drug levels. طيب, do you want to do anything special in view of the presentation which I gave you from outside?
Yeah, I want to do lipid profile. Lipid for the autoimmune antibodies.
Okay.
Yeah, we have glucose check, and hemoglobin A1C and random blood sugar.
Hemoglobin A1C, random blood sugar, agree with all the extra steps. All those metabolic complication of the steroid and the other immunosuppressive. Okay. طيب. Let's go through now the management. How you would like to manage your patient.
Management will involve multidisciplinary approach, involve the gastroenterology, the specialized nurse, specialized nurse, also the oncology. Sorry, I said sorry, specialized nurse, and also social services if need be, and regular follow up, and monitoring of the side effects side effect of medication. Then also monitoring for malignancy like squamous cell carcinoma or basal cell carcinoma, and then continue follow up and counseling of disease progression and monitoring basically, and then
And you
vaccine
would love to involve which team?
gastroenterology units and gastroenterology yes, and the
and the transplant team.
Transplant team. Yeah.
Okay.
Transplant
What
team,
is the differential diagnosis of itchiness in your case?
Yeah, differential diagnosis of itchiness include autoimmune hepatitis, include pulmonary biliary cirrhosis, pulmonary sclerosis.
Wait. Your patient had underwent a liver transplant. This means he have a healthy liver. So now, after having a healthy liver, he's having itchiness.
Yes, okay. Post itchiness, it could be due to side effect of medication. It could
Good.
be
like which medication we are usually looking for, which can cause pruritus?
Pruritus typically the
Azathioprine.
azathioprine, basically.
Okay.
Yeah.
And also sometimes a steroid.
Steroid too can cause
Okay.
itchiness too. Beautiful.
And
Then
irritation. But not
yeah.
common, but it can be for some patients. Okay, what else?
Then it could be
Differential.
reappearance of the original disease condition. Could be probably the
Good.
cause of the
Recurrence of the original
recurrence of
disease.
this
Okay,
condition.
what
Yeah, it could
else?
be a cause. Also, it could also be due to kidney uremia from kidney because
Uremia?
the tacrolimus can affect some of the medication can cause kidney injury. So the medication can cause kidney injury and then result to pruritus from uremia, from uremia
Okay.
basically. Yeah.
What else? Something more common. What can
Something
happen
more.
to the biliary system in after liver transplant?
Yeah, cholestasis basically.
Cholestasis, biliary
Yeah,
stricture,
biliary
leakage.
strictures, leakage.
Okay,
Yeah.
cholestasis, and also recurrence, as you said, and it could be biliary stone. What do you think?
Yeah, it could be. Yes, it could be. It could be.
Complicated biliary
Yeah.
stone.
Yes,
Okay,
it could be.
and did you notice that the transplant has failed? Any signs of transplant failure?
In this case, I wouldn't say transplant has failed because because there's jaundice, nuances of jaundice that we
There is
saw.
there is tinge
There's
of
jaundice.
interest. What else
Yes.
could
There's tinge of
indicate?
jaundice. Or
What
other thing
else?
that could indicate the failure could also be ascites,
Uh,
ascites.
no,
But
no,
in this
I'm
case,
talking about what was positive in the patient. Actually,
what's up?
you missed shifting dullness, right?
I think okay. Yes,
So
I
let's say that this patient have no ascites, but what was the two signs positive in this patient could confuse you with failure?
the
Icterus
jaundice,
and
yeah,
what
and the
else?
anemia and the pallor.
And the pallor, agree. What else?
And then also there's no flapping tremor, and
The
basically
mild tenderness when you put your hand over the liver, right?
beautiful. Yeah, you're right. You're
Okay.
right. Yes,
Now,
that's so
while
nice.
the other signs like flapping tremor, overload were negative, right?
Yeah.
Which I'm
They are
expecting to
negative.
be positive if there is liver failure. So I would say that he have a confusing sign which could be consistent with transplant failure, but it seems to be less likely because I couldn't appreciate a very obvious sign of decompensation. There was no flapping tremor, there was no signs of overload, the patient was not confused, no encephalopathy, right? Because he was
Yeah.
obeying your command, okay? Let's go now for the. You said pallor. Do you think iron deficiency anemia can be a good differential for itchiness?
Yeah, it could be. Yeah, it is. It can be. It can be. Sorry,
Okay, then now
it
if
can
I
be.
give you an extra sign, which I didn't give you, if I give you a positive lymph nodes in the neck, what important differential diagnosis you should add?
If there's a positive lymph node in the neck, it could be due to post-transplant
Perfect. You
lymphoproliferative
are
disease. Yeah.
very good in answering
Mm.
this. Yes, and it can explain the itchiness. Okay.
Yeah.
So you will
Yeah.
add this one and even you will give it a priority in listing your differential. So
Yeah.
again, we will repeat the differential because this is very nice a question. What is the differential diagnosis of itchiness in liver transplant? Biliary stricture or leakage or cholestasis? The
Mm.
cholestasis can be as a result of structural abnormality in the biliary system or medication induced. Second, recurrence of the original disease in the form of primary biliary cirrhosis or autoimmune hepatitis or whatever disease based on the patient age and gender. Third, differential medication induced either cholestasis or medication induced pruritus like azathioprine. Biliary stone or complicated biliary stone, okay?
Yeah.
A transplant failure in the form of decompensation, the itchiness and jaundice will be as a part of the decompensation. So you should have also associated decompensation signs. Fifth or sixth, differential anemia, iron deficiency anemia is known to cause itchiness. And if there is positive lymph nodes, I would go for post-transplant lymphoproliferative disease. And lastly, I will keep it last because يعني it is one good differential you gave, uremia, secondary to, but I need also extra supportive signs, secondary to immunosuppressive induced acute kidney injury. Okay,
Yeah.
so this is
Beautiful.
the full differential for itchiness. Investigation, we will revise. Let's revise the investigation.
Okay.
And see if you didn't tell anyone, because really I was looking for a good differential for itchiness in liver transplant. So every patient, if he is asymptomatic, he need a follow-up. Okay, we need to do clinical examination. We need to do a regular follow-up of blood pressure, which you didn't offer. You should ask the examiner. You should ask me about the pulse and the blood pressure. You skip the pulse and the blood pressure, which is a big miss in the
Yeah.
examination. Okay. And you should offer
Okay.
what also, not only blood pressure, blood sugar, right? Because
Yeah.
hyperglycemia, and you saw the prick marks in the tips. If there was no pricks, if there was no prick marks on the tips, what you should look for, which is a surrogate marker of the prick marks in the tips, nowadays is used more common than asking the patient to prick themselves regularly.
It's a CG and
You
continuous
are
glucose monitoring
perfect.
device.
Yes. So
Yeah.
you should inspect the dorsal aspect of the arm. Okay.
Yeah.
Okay. Then we have to go for now. So you will check regular follow-up for the patient if he's asymptomatic. Let's say that they ask you to examine the abdomen and there was no itchiness, no fatigue, nothing. Just go and examine the abdomen. So your investigation should start with regular follow-up, regular blood pressure monitoring, regular blood sugar monitoring, and surveillance for the side effect of the immunosuppressant, plus abdominal ultrasound to make sure of the state of the transplant. Okay, that's it. This is when we follow up any patient. But if he's symptomatic now, you will go in more details. Even for the regular follow-up, you will do the routine. CBC, LFT, RFT, and in addition to the blood pressure, blood sugar, and the regular ultrasound. Now you have to add, since your case have itchiness, so I would love to hear from you, LFT with synthetic function. And you will mention direct and indirect bilirubin, albumin, coagulation profile, right? So don't say LFT alone. I would love to hear the GGT, alkaline phosphatase, bilirubin, direct and indirect, those things which you need to judge about the cause of the icterus that the patient is having. Okay, RFT, okay, especially that the patient is on nephrotoxic medication, plus urine analysis and urine dipstick. That was a good thing to offer bedside. Then the cardiovascular risk assessment. Okay, the workup for cardiovascular risk assessment, including lipid profile for hyperlipidemia associated with immunosuppressant medication and hyperlipidemia associated with any primary biliary cirrhosis. So it will have two benefit in our condition. Okay, plus we mentioned already a full DM profile, fasting, OGTT, and hemoglobin A1C. Okay. In addition to the capillary blood sugar monitoring, which we offer bedside. Then I would do ultrasound plus ultrasound Doppler. You should say ultrasound Doppler. Okay. Any case of transplant, you should mention ultrasound Doppler. Okay. And also the ultrasound here, in my mind, I want to target what? The biliary system, because my top differential is biliary leakage and biliary stenosis, right? I was looking at, yes, liver, transabdominal biliary ultrasound. So you will, in your, when you mention the ultrasound, be like specific that I will do abdominal ultrasound with targeting the biliary system, and I would like to do Doppler ultrasound. Then, do you think that escalating from ultrasound to MRCP is logic in this case?
Yes, it's logic. It's logic.
Yes, because it will show me the
with the jaundice,
stricture.
yes.
Yes, the stricture and the leakage, especially if I gave a contrast. So, and the gold standard in any case of biliary leakage and biliary stenosis, what? Which is invasive and with contrast cholangiography, right?
Yeah.
Okay, so either you can do the cholangiography by ERCP or percutaneous. The invasive, I mean, okay?
Yeah.
It depends on how fit is your patient. So you have to mention those because your top differential is biliary stenosis and biliary leakage. That's why I told you, do you want to add any investigation in view of your
Yeah.
presentation from outside.
Yeah.
Okay.
Yeah.
So now we will end by alpha-fetoprotein, as you said, because you want to look for any complication. Okay, long-standing like HCC. And if there is any lymphadenopathy, I will add lymph node biopsy, and I will add tumor markers for lymphoproliferative diseases, and I will add a blood film, and I will add LDH for the burden of the disease, right?
Yeah.
So it
Yeah.
will be,
Beautiful.
you will add based on the additional signs and symptom you will find. Okay, if I find any
Okay.
signs of decompensation, I will add acetic tapping, I will add ammonia, whatever is present. Okay, even these days they are not very happy with ammonia. It's not anymore very important for encephalopathy, but at least the examiner will understand that you are investigating for the signs of decompensation and the liver and the failure of the transplant. And if there is any signs of transplant failure, everything should be preceded by the word urgent. Okay? Because you have an urgent differential or a serious or life-threatening differential. Okay? If your patient is septic because of the biliary leakage, then you have to add the septic bundle workup. So please, please, this case can go everywhere. Okay, can go everywhere. Now let's go through the management, then I will go through the steps. Management here is based on the top differential, which is biliary leakage. Most probably the examiner will discuss with you how you will manage any patient with biliary stricture or biliary leakage. What will be your answer?
For biliary leakage, definitely, like how to manage it, you have to confirm by the MROCP or the EROCP basically, and then you have to, if there's confirmation of biliary leakage, we need to do a we need to, because the MROCP will also assist in both will serve as an investigatory tools and also a therapeutic tools. You can also use it to correct the biliary leakage too. Aside looking at it, you can correct using the MROCP too, and then involve the general surgeons, the abdominal surgeons to help,
If there is complication or failure of the
there's complication.
endoscopic treatment.
Yeah.
So it
Yeah.
is maybe, did you say a stent?
Yeah, yes, it may be if after you've after once it has been confirmed, you may also use the same magnetic resonance cholangiopancreatography to also close the leakage. Do it
By the ERCP, and the closure of
ERCP.
the leakage can be by either what or what?
Can either be either an endoscopic or laparoscopic
Or percutaneous, or if there's
percutaneous. So yeah,
complication, laparoscopic.
percutaneous.
And you will use either stent or balloon, right?
Yeah, basically,
Okay,
yeah,
either
basically.
stent or balloon or surgical correction of the structural abnormality. Okay, so we are done with the management because it will be targeted to the first differential. Otherwise, if there is anything like liver, if there are transplant failures, so I will involve the transplant team. They will modify and review the immunosuppressant medication, and we will find the exact cause, like if it is stenosis, thrombosis, if there is recurrence of the original disease whatsoever. Okay, so this is the management. Now let's go for the steps of your examination. I will enumerate the steps as from the start, because I really forget what I want to say for you. I forget the exact steps you miss. First, I prefer to stand from far and ask the patient to cough and take a deep breath. Okay? Especially that this will give you an opportunity to inspect the abdomen early, and you will pick up the scar and you will give yourself extra time to examine things which you usually don't do. For example, you will add to your examination step proximal myopathy. You will pinch the skin. You will look for interscapular fat pad. Why? Just because you ask the patient from far at the start, while the abdomen is exposed, to cough and take a deep breath. Hello, السلام عليكم. Just a minute. السلام عليكم.
Okay.
ايه خلص انت قلت لنا جهزوا حالكم.
Okay, till Dr. Hen will join back. I will just comment for the confirmation, Dr. Henry. You asked for gynecomastia and she's female. Take care of this point. And also, when you present, you mention he is, which is also a point of welfare. You got it, Dr. Henry?
Yes, I do.
Yeah, take care of this. The gender, but in the exam, it will be clear. This is a gentleman or woman. You will know from the
No, Dr. Bass. I will cut from the welfare.
Yeah, okay. It's your revenge,
Noted,
Dr.
noted.
I
You can
agree
cut.
that it's an important notification, but we need to cut from the. I'm really joking, but
Okay,
you
okay.
made me you really bring something important to my notice, and I think
All
for
right.
you it is easier to remember she's a woman because you're looking at her, and for
Yeah.
me, I should be careful about the age. Really, يعني, even the pain. I always ask about the pain. How I forget it this time, I don't know. Anyway, thank you so much. بس والله دكتور باسم خليني بس خلص الله يوفقك لأنه حأمشي. وبصير بسمعكم من الزوم وانت بتكمل الكومنت تبعك فعادي.
Yeah. Go ahead. I
Okay.
thought you will take
فبعدين
time. It's
after
okay.
she cough and take a deep breath, you will come to the hand. See always the nails, the fingertip, leukopenia, clumping, and all those stuff. Wasting is always important to ask.
Mm,
And pinch
mm,
the skin and go for pulse, offer blood pressure, blood sugar. And if you feel any need, do not any need, always in the abdomen, do the tremor and flapping tremor. And then you will go up to the cubital fossa. I was very happy you asked about AV fistula. Okay, and then go up for
okay.
proximal myopathy, because in this case you might find a steroid side effect in the form of proximal myopathy. While you are going up, look for the bruises and spider nevi. If you find a spider nevi, please plunge them and count them and see
Mm,
the distribution. So plunge, count, and note the distribution. Then you will go up, you will look at the eyes. If there is any plethora, any pallor, any icterus, don't use jaundice. Always use pallor and icterus, okay? Because jaundice is a laboratory finding. Look for any alopecia, hirsutism as a sign of side effect. Look for any scars as a side effect of removal of a cutaneous cancer. Look for the cutaneous cancer which was not removed or skin tags. Okay, look for the JVP as a sign of overload and for the lymph nodes. It's very important in any abdominal station. Then you will go to the chest, look for any deformity, gynecomastia. Ask the patient to put his both hands on the loin. Look for any axillary, scanty axillary hair, or any scars, because sometimes there are lateral scars. Okay,
mm,
and then
mm,
you will inspect the abdomen for any deformity, any scars, any dilated veins. Okay. And then you will put the, I would love if you tell me, put the bed flat, lean on my knees, and be on the same level of the patient. Superficial
mm,
tenderness is the, and start away from the pain. Then deep organomegaly. Don't forget shifting dullness. Auscultation, you
mm,
did it very nicely. Kidney, you did it very nicely. Then you ask the patient any scar, spot the scar. Then you ask the patient to sit, look for any sacral edema by basal crackles, inspect spider nevi from the back, and look again for the scar because sometimes there's a thoracotomy or nephrectomy scars. طيب ماما بس أعطيني رنة بس يجي بابا إيه. Then you have to look for the lower limb edema. طيب خلص
mm,
حاضر. Then you will look for the peripheral edema, and after that you are done. Don't forget to offer bedside urine dipstick and bedside digital rectal examination, examination of the remaining lymph node groups, because you only did cervical, right?
okay.
And bedside ultrasound.
Okay.
Okay. And if you
Okay.
didn't do the private area, tell about the private area. If you didn't do the lymph nodes at all, whatever you missed, please offer it at the end. It's okay. At least you will take borderline rather than getting fail in the station. Okay.
Okay. Okay.
This is regarding the steps. Regarding the presentation in any organ transplant, you have to comment on the general findings and don't comment on the things which you can group. If you can group the skin thicken, the thin skin and the prick marks, and if you find round face, don't scatter your findings. At the end, group them under side effect of immunosuppression. Okay, so I will
Mm,
first enumerate the general finding, then the local finding. And the scar that you have is called Kucher or chevron or Mercedes
Scar.
Benz? What is the name of your scar?
Yeah, Mercedes-Benz car.
No, not Mercedes Benz.
No,
Use
no, 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 no. I was trying to mention the car that no, this particular car is not Mercedes-Benz car. I'm just you're mentioning this car, so I was trying to complete this cars for you.
Okay, so see,
Uh,
and modified. Okay, so three types of scar. Which type is
yeah,
your patient?
this the patient has a Chevron car.
Oh, okay, Dr. Bas. طيب, okay. And then I would, so it is chevron? No, chevron is bilateral costal incision meeting in the midline. See, I put the scars for you on in the group. Okay, so bilateral subcostal is chevron, while only subcostal on the unilateral is Kucher. Okay, and the modified Mercedes-Benz or modified Mercedes-Benz scar, where you have two limbs, not three limbs of the Mercedes-Benz. Mercedes-Benz has three limbs, right? So you will have
Yeah, yeah.
a unilateral subcostal plus the midline. This is the modified Mercedes-Benz, okay? Without the subcostal, the other subcostal scar. Only one subcostal plus the midline. This is modified. Mercedes-Benz, complete Mercedes-Benz. Chevron, bilateral subcostal meeting in the midline. Kucher is one subcostal scar on unilateral. Okay, there is no other one. And if they are not meeting in the midline, it will be bilateral Kucher scars, not chevron. Chevron, it need to meet in the midline. Okay? So always remember, if you forget the name of the scar, use the anatomical description. Subcostal, bilateral, meeting in the midline, whatsoever. It's okay. Okay? If
Okay.
you forget the name.
All
What else I want to tell you? Signs of there would be many, 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 many nice questions, but let's end it here because they will kill me, my parents.
right. Yeah, yeah.
Okay.
Thank you. Thank you so much. Thank you.
I hope really you enjoyed it.
Yeah, I did. I did. Thank you so much.
Okay, so from my side, I'm done. Let's listen to Dr. and I will listen to Dr. Basim comment. See you.
Okay. Thank you.
Okay, thank you, Dr. Hind. I cannot comment after your explanation. Really, it's a nice
Yeah.
topic.
It's
From A to
extensive.
Z,
Yeah.
the transplant, the causes of liver transplant, liver failure, chronic liver disease manifestation, compensated, decompensated. You mentioned everything.
Yeah.
Even the scars Dr. Hind already mentioned. I wrote it in the chat box. So it's Kocher or Kocher scar. This is for cholecystectomy. Could be also for liver transplant. You might have rooftop scar or Vitchen, as Dr. Hind mentioned, so inverted V, or you might have Mercedes-Benz or J-shape. All of them can be used for transplant. Some doctors or one doctor asked about why I cannot say this is cholecystectomy. So they will not bring a case in paces, abdominal paces, I mean, to say this is cholecystectomy case. Yeah, it's a differential cholecystectomy scar, but it's not the case of cholecystectomy. You have to put it under the differential of this scar. Usually, they bring such scenario like liver transplant or renal transplant, hepatosplenomegaly, splenomegaly only, and that's it. These are the possible cause of the possible presentation. You might have also adult polycystic kidney disease with or without renal replacement therapy. So our case today as liver transplant, what is the underlying cause? It's for differential. You can put a lot of differential here. As we had diabetes, you can put along with the diabetes autoimmune hepatitis as a differential or other possible cause. According to the gender, according to the age group, you can put different differential according to the differential or according to the gender or the age group. The management, the investigation, everything mentioned, even the ultrasound, Doppler, Dr. Hosni was asking, Doppler always to assess the vascular assessment for the transplant, if there is thrombosis or something might be there. The investigation, including all of the liver function, you have to add always drug level. Not only during the investigation, you have to mention it while doing the examination. I could find the side effect or toxic effect of these medication. Steroid, MMF, mycophenolate, or cyclosporin, calcineurin inhibitors. Whatever you have, any of them, tacrolimus, the gum hypertrophy, tremors, any side effects you have to mention. Myeloproliferative, lymphoproliferative, post-transplant lymphoproliferative, cancer of the skin, squamous cell, all of them you have to mention if you have find any of them. Or you can roll them out by saying I couldn't find. Okay. The management always treat the underlying cause. What's there you have to mention. Is it infection? You have to give antibiotics or according to the biogram. If there is rejection, you have to mention how to deal with it. In the top of your management, you have to call the transplant team. Makes sense usually while you saying anything. Don't say haphazard. So whenever you have transplanted organ, the first team to be there, the transplant team, kidney or liver. Pancreatic also present in UK, so you can mention the transplant in the top of your team. Multidisciplinary team approach, usually you are mentioning in any case in PACES exam. Later on, if you want to specify medication, you specify pharmacological, non-pharmacological, you can talk about any of them according to your case. Okay, usually, as I said, rejection, infection, recurrence of original disease might be there. So you have to mention these are the possible complication and how to deal with everyone. Doctor, I mean cholecystectomy as a case of chronic hemolytic anemia. It appear in cases. Yes, definitely. Yes, you're right. So you mention it along with the splenomegaly, for example. Yeah, you're right. But it will not be like isolated cholecystectomy. You're right. It comes as cholecystectomy associated with chronic myeloid leukemia. Sorry, chronic hemolytic anemia. In particular, the as we know, all of us, the most common thalassemia. Thalassemia in every diet, in every center, they have a case of thalassemia. So one of the major operation or one of the surgery and differential of scars, cholecystectomy. You're right, doctor. Thank you for the notification. But I said single or isolated cholecystectomy as gallbladder. I mean, they will not bring calcular gallbladder or post-calcular cholecystectomy. Okay, this is what I meant. But yes, definitely they bring it as thalassemia. Okay, Dr. Hind add also last comment. Presentation should include general inspection signs, name the scar, the localized scar, then the localized finding like tenderness, any abnormal finding, functionality of the transplant, side effect of immune suppression, end up by signs directing toward the etiology. Exactly. As in this scenario, you have to mention the diabetes or finger prick mark as a finding. Okay, any question, Dr. Henry? Anything you want to ask? Anyone want to ask any question? Any comments?
No, thank you, Dr. Baz.
Oh, okay, thank you. You are more fluent, more confident, but take care of the welfare points. Sometimes you are forgetting and you are mixing while presenting. Usually, you have to, whenever you have liver transplant or liver patient or hepatic patient, look for the axillary hair in the male and gynecomastia. Okay, caput medosa and spider nevi, even at the back, not to miss it. They are very important. The tremors, of course, jaundice, all of them, the ascites, all of them as decompensated liver disease or decompensated chronic liver disease. Okay, anyone want to add any question or comment? Can you talk, sorry, Dr. Hasni, more about welfare, please? So the welfare, I will tell you when you can touch the welfare of the patient. For example, if you say bad word to the patient or the patient feel like you are talking, shouting at him, this is by in the history taking, okay? If you said, for example, because of your obesity, this is one of the welfare point. Whenever you hurt his feeling, by any word, they might minus you in the welfare. Okay, some also with the welfare point if the patient is having eye or vision problem and you didn't ask about driving. Okay, so it is very important. So the welfare will be also affected. Let's go to the examination. Of course, the smoking, the alcohol, the support, all these things does make sense that you have to ask to offer to help the patient through them. Examination wise, if the patient fall down, if the patient say or he feels pain, particularly if you didn't prepare him, if you touch him with your cold hand, if you touch him with your cold stethoscope, and he felt some pain, even without shouting. You know, the face expression can show the examiner that he felt the pain or he felt the coldness. But to avoid that, initially, before examining any patient, as we do usually, Sir, or sorry, Mr. X, if you have any discomfort, any pain, let me know. I'm so sorry if my hand are cold. This is what I used to say before examining any patient. Okay? I'm so sorry to if you feel any pain, let me know. If you feel any discomfort, stop me. I'm so sorry if my hand are cold for you. And try to warm your hand. The stethoscope as well. All the things might affect your welfare marks and you couldn't feel it. And will come out, okay, you feel like you did well, but in the exam and the marks, you will find the welfare affected. Take care when you are doing the Babinski, the patient her legs will not hurt the end of the bed. The patient, while you are doing coordination, the patient might fall or he hit the wall or he hit the end of the bed. Okay, all these things might affect your welfare marks. Okay, I give some examples. Maybe there are others, but it's the very common. Also, the sanitization. Whenever you start the examination, some examiner the minus the candidate if they didn't do the sanitization. Okay, so always do alcohol rub for your hand before touching the patient. Some tough examiner they consider it as welfare, but usually most of the examiners they are kind and they are reminding you before starting examination or even entering the station. They will give you the alcohol to rub your hand. But if you miss, some examiner they might minus you as well. Is it clear, Dr. Hasni? Yes. Take care of this, and with the practice, you will know more about them. Anyone has another question or comment? Any question before ending the session? Okay, thank you, Dr. Henry, Dr. Hind as well. Where to read more about liver transplantation, Dr. Hasni? Okay, there is, I think, a Maghrabi book, and you can read from any website, you can read from any book. I will send you some books, Dr. Hasni, privately, okay? I will
بس
send
إضافة
you.
بس إضافة
Yes,
بسيطة، ما ننسى إنه هي women ممكن we need to counsel or take care about her pregnancy. And we
yes,
always need to check for any lady, uh,
yes,
review her medication, make sure she's on proper OCPs or like birth
perfect.
controlling methods. يعني sometimes recently أي young women بياخدوا هالموضوع على محمل الجد بالمانجمنت. They will take it يعني accountable if you mention it. تمام؟
Yes, you're right. Anything can affect the pregnancy or future pregnancy, and you didn't touch it, you didn't raise it, it will also affect your welfare part. So anything can harm the patient directly or indirectly, and you didn't counsel it or you didn't ask it, it might minus you. not only in the clinical judgment, sometimes it might touch the marks of welfare. Thank you, Dr. Hind, for reminding about this point. Anyone want to add any question before ending the session? Yes, thank you, Dr. Hosni. So we can wish you a nice and happy weekend. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.